Hi and welcome. Again, my name is Maureen Oscadal and I'm a registered nurse in Seattle, Washington. I'm here with the University of Washington's Addictions, Drug, and Alcohol Institute, and this is the Nurse Care Manager Foundational Series. In this next video, we'll talk about addressing ongoing and return to substance use, and we'll get started now. Opioid use disorder, like other substance use disorders, is a health condition that affects the brain. As we discussed in the introduction, a person's vulnerability to opioid use disorder, or OUD, is due to a combination of genetic predisposition and environmental precipitants. It's a chronic condition, and over the course of a lifetime, OUD symptoms, severity, and sequelae can vary, and it's not uncommon for people with opioid use disorder to experience patterns of relapse, also known as a return of symptoms or a return to use, as well as remission. It's important to frame an episode of return to use or relapse in symptoms as a learning opportunity. For example, it can be helpful to help the patient identify the context and circumstances surrounding their return to use and brainstorm strategies that the person may want to try to prevent using in the future. Substance use disorders also tend to follow patterns that are similar to other chronic health conditions that we treat in clinical practice. Here we see how SUD, or substance use disorder, compares to asthma, hypertension, and type 1 diabetes in terms of relapsing symptoms. And perhaps because of the similarity in treatment adherence, there are also similar relapse rates across all four of these disorders. This outcome study indicates that 30 to 50% of adult patients with type 1 diabetes and approximately 50 to 70% of adult patients with hypertension or asthma experience a recurrence of symptoms each year to the point where they require additional medical care to reestablish symptom remission. This compares to 40 to 60% of adults living with substance use disorders who also experience recurrence of symptoms each year to the point where they require additional medical care to reestablish symptom remission. And while we may be seeing a person for opioid use disorder treatment, it's also important to note and recognize that polysubstance use, meaning the use of different substances, is common. In this survey of around 15,700 patients entering opioid use disorder treatment, conducted between 2011 and 2018, more than 90% reported using at least one non-opioid substance in the past month. In this other study that looked at a subset of surveys from 2012 to 2013 among individuals living with opioid use disorder, out of the 356 surveyed, 332 individuals with opioid use disorder, or 93.3%, reported using 2 or more substances in addition to opioids in the past year. And 57.3% had both opioid use disorder and at least one other substance use disorder. This chart shows some of the most commonly reported substances used in addition to opioids among the survey participants. While this data is now over 10 years old, it serves to illustrate that the use of multiple substances is common among people living with opioid use disorder. So how do we talk to patients about their substance use? Well, we'll talk more about the impact of stigma in the next video. However, it is critical to acknowledge and be aware that stigma related to substance use and substance use disorders is a significant barrier for our patients. Consequently, it's incredibly important that when nurse care managers and others who are part of the care team talk to patients about their substance use, that they make an effort to normalize the conversation, because it involves talking about something that is difficult, something that people rarely ask about, and something that people are taught is shameful, which leaves them in isolation. When we ask patients about their substance use, it's helpful to let them know that these are questions we ask everyone at each visit and explain why the information is helpful. For example, knowing what substances a person uses, when and even why, can help the nurse care manager to better support the patient to work toward their own goals of care. When we talk about these topics, it's important to maintain neutral tone and body language and to use non-judgmental language. One way to do that is to ask open-ended questions. For example, what substances have you used since our last visit? Instead of, did you use any substances since our last visit? Or worse, you didn't use any substances since our last visit, did you? Open-ended questions tend to carry less judgment, but the answer can also provide the clinician with more information while allowing patients to answer in their own words. It's important and recommended to continue buprenorphine for opioid use disorder treatment, regardless of ongoing opioid use or other substance use. However, some adjustments may be considered to improve the medication effectiveness, including adjusting the medication dose, changing the medication formulation, for example, from films to tablets or from sublingual to injectable, and or increasing appointment frequency for added support. One approach that nurse care managers can employ during visits is motivational interviewing, or MI. MI is a counseling approach that seeks to help people strengthen their motivation and commitment to behavior change. Nurse care managers can use MI to help patients identify barriers and facilitators to changing their use, and the reasons why they are motivated to change the behavior. This technique discourages what's called the righting reflex, which is the tendency of healthcare staff to advise patients about what they should do. The righting reflex can have a paradoxical effect, which leads to this unintentional reinforcement of this status quo. Instead, MI encourages patients to identify their own hopes, the reasons behind them, and how they want to achieve them. This is accomplished through asking open-ended questions, actively listening, and highlighting what's called change talk, which are patient statements that show they're considering, motivated by, or committed to change. The nurse care manager's role is to guide patients to express change talk, which can help people to develop a rationale for starting change in their own lives. Nurse care managers should be familiar with strategies for reducing the harms and risks associated with ongoing substance use. Oftentimes, patients are already employing harm reduction or safer use strategies, so it's wise and helpful to ask patients what they're already doing. This allows patients to share their own expertise and experience, and also provides the nurse care manager with the opportunity to reinforce efforts already being taken. If you wish to offer additional information about safer use, it's recommended that you first ask the patient's permission, and then follow up by asking what they think about the suggestion. You should be familiar with harm reduction resources in your area so that you can share information with patients as needed. And additional information about safer use strategies for a variety of substances is available via the University of Washington's Harm Reduction Research and Treatment Center. There's a link at the bottom of this slide. As previously discussed, opioid use disorder is a chronic health condition. And like other chronic health conditions, symptoms of opioid use disorder can remit and relapse. Patients may not immediately report a return to symptoms or a return to use. And in these situations, there may be some signs to pay attention for, including missed appointments or calls, early refill requests or late prescription fills, lost medication, reports of withdrawal or cravings, decreased social functioning or increased isolation, or changes in mood. A return to use can bring a lot of shame, guilt, and self-stigma for patients. So it's important for the nurse care manager to avoid saying and behaving in ways that might add to the burden the patient's already feeling. So if we notice signs of a potential return to use, it can be helpful to approach the patient with a supportive, non-judgmental attitude to help them disclose what's going on, because ultimately the goal is to support patients through this process. It can be helpful to ask open-ended questions when we're doing this to allow them to share in their own words. And one example of an open-ended question might be, I've noticed that you've missed a few appointments recently and you filled a script late recently. what do you think? And also we could ask patients, what do you think would be helpful? When discussing current substance use with patients, it's good to get the story. And here are some possible questions that can help you and the patient to better understand the story behind their ongoing or return to substance use. So first, what did you use this past week, or what have you used since the last time we saw each other? And making a practice of asking this kind of open-ended question at every visit can help normalize the conversation. And then as a follow-up, finding out what happened. What substances were involved? Who was there? What were you doing? What were they doing? How were you feeling? What were your thoughts? What were your moods? And if something changed, what was it and how did it change? And then finally, we want to encourage self-disclosure. So it's important that we thank patients for sharing when they share with us. And also, we need to be transparent and inform patients of any consequences of them disclosing their use to us. At every visit, it's important to check in about how the medication is working. We can do this by asking about symptoms of withdrawal and cravings for opioids. For patients who are taking sublingual buprenorphine, we can assess medication adherence by asking questions like, how often do you take the prescribed dose? Do you ever forget to take the dose, or do you ever hold the dose? If someone has extra medication left over when they're due for a prescription, that's an indication that they're not getting every dose. If they take the dose more than once a day, how often are they spacing those doses? And when they take the sublingual buprenorphine, how long does it take for the film or tablet to dissolve under the tongue? As a reminder, it should take at least 5 minutes. We also want to make sure patients do not eat, drink, smoke, or talk while they're letting that medication dissolve under their tongue. And finally, we can confirm that a person is taking sublingual buprenorphine when it shows up in the urine drug screen results. In situations where the topic of intensifying treatment in response to ongoing or return to use comes up, it's best to hear from the patient about what they think is going to be the most helpful. This is part of the shared decision-making process, which encourages the inclusion of patient input in treatment planning. Patients often have ideas about what might be helpful, and they also frequently know what they do not want or what has not been helpful in the past, and all of this information is important and should be considered. This does not mean that the nurse care manager cannot or should not provide guidance or suggestions, but it is best to provide options for the patient to choose from rather than simply telling the patient what to do. Above all, these conversations should be centered around the patient's own goals of care. So we can intensify treatment both within the same care setting and in a new, more supportive or a higher level of care. And on this slide, we have a list of ways that medication for opioid use disorder treatment can be intensified within the same care setting. So we can offer increased frequency of visits or phone calls for support between visits. We can help the patient connect with mental health care services, either in our own setting or in the community. We may identify recovery support meetings for the patient to attend, or we could connect the patient with peer support. And if appropriate, we could discuss the possibility of adjusting the medication dose with the patient's prescriber, or if it's available, a formulation change, for example, switching from sublingual buprenorphine to long-acting injectable buprenorphine. If you think the patient may benefit from a more intensive treatment setting, it's best to start the conversation early and to revisit the topic at follow-up visits. When talking about transferring to a higher level of care, it can be really helpful to frame it as, this is not the right treatment right now. Transferring care to another setting can take time, both because of the availability and patient readiness. So whenever possible, buprenorphine should be continued until the patient has completed that transfer. And to the best of your ability, provide the patient with options. This requires having a working knowledge of other treatment options available in your area, including services offered and intake processes. Finally, one last note. In my experience, this process only works if the patient is in agreement. Otherwise, there is a good chance that the patient will stop engaging in care altogether. As we start to wrap up, I want to return to the point that opioid use disorder is a chronic health condition characterized by periods of remission and relapse. And that's not dissimilar from other chronic health conditions that we see in clinical practice. However, while that's true, a return to use can be distressing and disappointing for patients. In these situations, I like to remind them that treatment is a process, and I frame a return to use as a learning opportunity. One way we can do that is by helping patients to identify 3 things. First, risk factors. What are the circumstances that put the patient at risk of using? Sometimes people will refer to these as triggers. You can ask the patient to think back before they used and recall what was happening. What kinds of stressors or events may have contributed to the return to use? Second, you want to review the patient's protective factors. What are some things that serve as sources of support and protection for the patient? It could be a loved one, an animal, a hobby or an activity, their job or schoolwork. Are they engaged in mental health care, or do they participate in recovery support meetings? Like risk factors, protective factors are unique to the patient. Finally, discuss coping skills with the patient. There may be some overlap here with protective factors, but these are more specifically skills or actions that the patient can perform when they're exposed to risk factors. They may include activities that help to reduce stress or that serve as distraction. You might ask the patient what skills or activities they have found helpful for coping with difficult situations in the past. You may also inquire about whether there are any new skills or activities they would like to try, and then at future visits, check in with the patient and ask how it's going. Have they been able to practice the coping skills in response to risk factors? If so, how did it go? This concludes the video for ongoing and return to substance use. Again, thanks for joining me. The next video will be the last video in the Foundational Nurse Care Manager series, and in that video we will cover the topics patient engagement and retention and care.